We'll start, sir.
Right.
Good afternoon, everyone. Thank you so much for coming. We're very happy to welcome Dr. Sanjit, Professor in the Department of Neurology. Sir is go-to person in regard to strokes, especially. So, sir is going to discuss on management of intracranial hemorrhage, which is one of the most common strokes which we see in our department. Thank you so much, sir, for coming. Over to you, sir.
So, good afternoon, everyone. So, today we'll be discussing the management of intracranial hemorrhage. So, we'll start with a small case. So, we have a 60-year-old man who's a known hypertensive and who has come to you within 3 hours of having a acute left-sided hemiplegia, and his blood pressure is found to be very high, just 200 by 120. Pulse is 88, and his GCS is little bit on the lower side, 12 by 15. So immediately you have done a scan, and the plain CT scan has been done, and it shows hemorrhage. Now you're called to see this patient as a PG registrar, and you know it's a hemorrhagic stroke. You told the patient's son that your father is having a hemorrhagic stroke, and he's asking these 3 questions. The first thing is whether it's a serious condition, and you told him yes, he has a bleed. Then he's asking you whether we can give him any medicines to stop the bleed, and he's also asking you whether you can do any surgical intervention to save him. So the next few slides we'll be looking at the current literature on this and trying to answer these 3 questions. So what we have is here is a patient who has intracranial hemorrhage. As per definition, it's a focal collection of blood within the brain parenchyma or ventricular system that is not the result of trauma. It's also called spontaneous ICH, non-traumatic ICH, or primary ICH. Now, intracranial hemorrhage constitutes 15 to 20% of all cases of stroke, and especially in India and other underdeveloped countries, the incidence of hemorrhagic stroke is slightly more than this. Now, there are a lot of causes for intracranial hemorrhage. The most common is hypertension, amyloid angiopathy, coagulopathy, AVM with bleed, aneurysmal bleed. You can have a cavernoma which can bleed. You have neoplasm, a tumor in the brain which can suddenly bleed and look like a intracranial hemorrhage. And you can have cerebral venous thrombosis, vasculitis, and some drugs which can also cause intracranial hemorrhage. So the most common of these are hypertension and amyloid angiopathy. Due to some reason, we see most of our patients having hypertensive bleeds. So you should know the common sites for hypertensive bleeds. So that is in the order of common presentation. I mean, like first of all, you see it in the putamen, then in the thalamus, and then in the pons and in the cerebellum. These are the common areas where you can get hypertensive bleeds. So if you have a patient who comes with a very high BP and bleed in one of these 4 sites, then you can be very sure that it is because of hypertension, and you need not investigate further unless there is some other red flag in that patient. Now, you should know that there are a lot of drugs which we commonly prescribe, which can cause or even contribute to the bleed. The most common is antiplatelet agents, both aspirin and P2Y12 inhibitors like clopidogrel, and also oral anticoagulants, both the traditional and the newer anticoagulants. There are some other medications like selective serotonin reuptake inhibitors and statins, which can also be cause or contribute to the bleed. Now, if you want to understand how to treat these patients, we need to understand the pathophysiology. So when a patient has intracranial hemorrhage, they pass through 3 stages. So the first stage is the stage of hematoma expansion and stabilization. And the next stage is the stage of mass effect. And then you have a stage of resolution and retraction of the bleed. So let's see what happens. So as soon as you have a bleed, the bleed will expand and then you will get a large hematoma, which will stabilize after a few hours. So immediately your primary injury will start. The brain, there'll be destruction of brain tissue, can have mass effect, and this will cause a rise in the intracranial pressure, and some patients can immediately go in for herniation if it is a massive bleed. The important thing here to understand is when you have a patient coming to you early, the hematoma expansion is occurring. It goes on occurring for the first minimum for the first 6 hours. So if a patient is coming at 3 hours, he's still bleeding inside the brain. So that's a very important concept to understand. So if you look at this serial CT scans, you can see at 3 hours, the patient is having a small bleed. By 6 hours, it has expanded so much to cause obliteration of the ventricular spaces, and also there is a mild midline shift happening. So all this can happen within the first 6 hours. The next stage is what you call a stage of mass effect or mass stage, where you have what you call as a perihematoma edema, which will develop around the area which has bled. So after this happens, your primary injury is only increasing. There will be more damage to the brain, mass effect will increase, and ICP is going up. So this is a very dangerous stage, the second stage, where there is potential for herniation. Now coming to the perihematoma edema, this is a complex mechanism. So this starts off by the expanding hematoma causing a osmotic pressure gradient, and there is a break in the blood-brain barrier. And initially, there will be a cytotoxic edema, and later on, you can have both cytotoxic and vasogenic edema occurring in the brain. Studies have shown that there is a triphasic pattern of growth for this perihematoma edema. So there is a very fast growth phase in the first in the first 1 to 3 days, and there is a phase of slow growth subsequently, and it can occur even up to the first 3 weeks, the edema. But whatever it is, the maximum volume of the perihematoma edema is occurring within the first 24 hours. So that is another important concept we should understand. Now, if you look at this scan, it's an example, classical example of how perihematoma edema can increase and cause problems. You see, as the first 1 hour, you have only the bleed there. As you see the subsequent scans, you can see there is edema forming around it. And by 21st day, the bleed has a little bit regressed, but the edema is increased, and that is what is causing the mass effect. So both your bleed, the blood, and as well as the edema can contribute to the mass effect. Now we have the third stage, which is a stage of resolution of the hematoma and clot retraction. So in this stage, even though the clot is retracting, the blood products which is there will release neurotoxins, and these neurotoxins will be taken up by the neurons, and this will cause cell death. Now, there are a lot of mechanisms involved here: excitotoxic cell death, oxidative stress, and inflammation. So all this will cause late complications or late effect of the bleed in the brain. So now, understanding the pathology, hopefully we'll be able to answer these 3 questions which the son is asking you. The first is my father serious? Okay. So what you should understand is hemorrhagic strokes are more dangerous than ischemic stroke. The mortality is in the range of around 40%. And even if the patient survives, the functional disability is around 60 to 80%. So now we have a score called the ICH score, we can use to prognosticate these patients who present with a bleed. So this is the ICH score. So you have the GCS. You have to calculate the score using GCS, the volume of ICH, whether there is a intraventricular extension to the ICH, whether the bleed is occurring infratentorally or supratentorally, and also the age of the patient. So totally you can get a maximum score up to 6, and anybody having a score of more than 4 or 5 means very bad prognosis. What this score does is it will predict the mortality at day 30. But there is a catch to this. As we saw earlier, the hematoma can expand up to first 6 hours. Okay. After that, you have the edema, which is settling in. So if you look at this patient, if you score this patient, as soon as he comes within the first 3 hours, your mortality is good. It's almost 0% mortality with a 70% chance of being independent. The same patient, if you score after 3 hours, maybe after 4 to 5 hours, your mortality is 30%. Okay. Also, after that, you have your perihematoma edema, which is contributing to the whole picture. So if you are using this score, the main thing you should understand is wait at least 48 hours to 72 hours. Then only you should use this score to prognosticate any patient. Otherwise, it will be disastrous. You might score a good score and patient will deteriorate in the next 24 hours. Right. Now, there are some imaging predictors which will tell you that this patient's hematoma is likely to enlarge. So you can use your plain CT scan or CT perfusion. There are 3 signs on imaging. So the first sign is called the CT angio spot sign. So what you're seeing is a plain CT scan, and you can see there is a bleed with the intraventricular extension. Now, the same patient, this is a CT angio. Okay, you are injecting contrast and you are looking at the CT angio source image, and you can see here in the area of the bleed, there is an area of where the contrast is concentrated. Okay, so this is called a CT angio spot sign. And this, if you have this sign, it corresponds to a site of active dynamic hemorrhage. The bleed is, basically you are seeing the ruptured vessel pouring out blood. And this is the independent predictor of poor outcome. And if you do a CT angio for patients coming to you with hemorrhage in the first 6 hours, the sign can be seen in up to 30% of patients. The next sign is called the CT blend sign. So blend means you have here, this is a plain CT. This is a sign which you can see it on the plain CT. So here you can see on the plain CT, you can see hyperdensity. Around that, there is another area of hyperdensity, which is slightly different. Okay, it's called the blend. So there are 2 hyperdensities, which is nearly blending. And the difference between these 2, if you look at the Hounsfield unit, should be at least 18. So this is what you call as a CT blend sign. This also means that there is active bleeding going on and the hematoma can potentially expand. So you see these 2 signs together. If you do a plain CT, you might see the blend sign, and the same patient, if you do a CT angio, you'll see the CT angio spot sign. Now the third sign is called the CT black hole sign. So it's a plain CT again. So you can see there is an area of hyperdense area of bleed here, and inside that there is a black sign, black hole there. This also signifies there is an active bleeding vessel. So there are many other signs, but these are the 3 common signs you can use to predict hematoma growth. Right. So the next, so using the ICH score and some of these imaging signs, you can predict whether the patient is going to bleed more and what is his prognosis. But you should wait for at least 48 to 72 hours. So the next question you have been asked is whether you can give any medicine to stop the bleed. So hemostatic therapies in ICH can be divided into 2 major groups. One is the pharmacological therapies and then blood pressure lowering. So we'll just look at the latest literature on these two. So this is recombinant factor 7, which came up in a big way. What this does is it promotes hemostasis, activating the extrinsic pathway. However, the clinical trials did not show any benefit with this agent, but moreover, it showed harm. The patients who received these agents were having more of thromboembolic events, especially myocardial infarction and ischemic stroke. And so there is a level A evidence of harm if you use this drug in a patient with intracranial hemorrhage. And currently, you should not be using this drug outside clinical trials. The second drug is tranexamic acid. So this stabilizes the clot. So there have been trials which have looked at this in ischemic stroke. That's the TICH-2 trial, where you give this drug within 8 hours of symptom onset and look at the MRS score at 90 days. The trial was negative, but however, there was some observed fewer deaths at day 7 with tranexamic acid. And also this drug is much safer with fewer adverse effect compared to placebo. In fact, this drug, the patients who would receive the drug had less side effects compared to placebo. So there are two trials which is ongoing. One is called the fastest trial using activated factor 7 very early, within 2 hours of the window period. And the second trial is called the intrinsic trial. That is the Indian trial of tranexamic acid in spontaneous intracranial hemorrhage, where you can give this drug within 4.5 hours window. And we are also, our department is also part of this second trial. Now, most often you will have a patient who is already on aspirin or clopidogrel or a combination of both, and who has presented to you with a bleed. So it's a very common scenario. Studies have shown in such patients, the in-hospital mortality is very high, especially if you are on dual antiplatelets. So the question is, should we give platelet transfusions in these patients who are already on antiplatelet agent? The trial which looked at this was the patch trial. So that is, you compared patients receiving platelet transfusion comparing with placebo after ICH. So this trial also was a negative trial. Also, there was a higher death or dependency in the patients who received platelet transfusion. So platelet transfusion is not only ineffective, it also can cause potential harm for your patient. What about oral anticoagulants? You use warfarin, acetylrome. So patients, if you look at all the patients coming to you with the ICH, the patients who are taking these drugs will constitute up to 20% of your ICH patients. And so the main thing here is these patients do badly because, as we saw earlier, the hematoma can expand even otherwise. But in these patients, it's not 6 hours, it will expand even beyond 6 hours up to 12 to even to 24 hours. So that's why these patients do very badly. So you have two choices here. One is you can give fresh frozen plasma, or you can give what you call as a prothrombin complex concentrate, or PCC. So both of these can be tried. Earlier, we used to give patients fresh frozen plasma. But now trials have shown that if you compare these two agents, there was a trial which was done to see how fast your INR can be brought to normal. And it was shown that PCC has a very, very high effectiveness in this. 67% of PCC patients achieved the target INR, whereas FFP only 9%. Okay. So any patients on warfarin or syndrome coming to you, if you want to achieve a fast INR, you have to use PCC and not FFP. Also, there are other advantages of using PCC. One, you don't need any preparation. Whereas in fresh frozen plasma, you first have to get it from the blood bank, thaw it, then you give. Whereas PCC is just injection, just reconstitute it and just inject it. The second thing is the administration time. FFP, you need at least 3 to 4 hours to infuse it, whereas here it's just a bolus of 15 minutes. You just give it and finish it out. So these are also advantages for a patient who presents, especially acute intracranial hemorrhage. What about a direct oral anticoagulants associated ICH? So we use all these reagents regularly now: dabigatran, apixaban, rivaroxaban. So all of these agents have their own specific antidote. Like dabigatran, you have idaruximab. Like that, each of these agents have their own reversal agents, but however, all of them may not be available. So if you have a patient, you can still use your prothrombin complex concentrate if these drugs are not available. And the thing is, these drugs are very costly. Like idaruximab, for a single patient, it will come to around 1.5 lakhs. So whereas PCC is very cheap. Now, the next thing we can do to stop or decrease the hematoma expansion is by acute blood pressure lowering. So this is something of a controversial field here. So why you want to reduce the blood pressure? It is known that if you have a high BP after ICH, it's a predictor of poor outcome. These are the patients who have a greater hematoma expansion and neurological deterioration and death. So the question is, if you lower the blood pressure, will it translate into better outcome? So that's the question. So there has been 2 trials which had looked at it. One is to call the Intract-2 trial and the Attach-2 trial. So this is the Intract-2 trial where you got patients within 6 hours of onset with a high BP of 150 to 220, and you brought down the BP to less than 140 within the first 1 hour and maintained it for 7 days. However, this trial was negative, but there was some difference in the overall modified ranking scale at 90 days. The next trial was the Attach-2 trial. Here, the systolic, again, the goal was to reduce it within 4.5 hours instead of 1 hour. And it was comparing, bringing the BP down to 140 versus maintaining it above 140 but less than 180. And here also there was not much difference, and there was some noise that there was higher renal events if you bring down the BP very fast. So what we understood from all these trials is, any patient who comes with ICH, you need to assess the BP very closely in the first 24 hours. Every 15 minutes, your BP has to be checked. And so BP is 150 to 220. You can reduce it to less than 140 in the first 1 hour and maintain it. But if the systolic BP is more than 220, then you should reduce it to less than 220 in the first 1 hour. And subsequently, you gradually reduce it to 140 to 160. Don't bring it down too much. So this is what we understood from all the trials. And who are the patients who will benefit maximum from these trials? One, if the patient is reaching you very early, less than 6 hours from the symptom onset, patients on oral anticoagulants, and those with the neuroimaging markers of expansion, like the spot sign, all the blend sign, all these patients definitely will benefit if you control the BP in the acute stage, that is less than 6 hours. What are the drugs you should be using? The best drug is very short life drugs, which is easy to titrate, like IV labetalol, and also some studies have used nicardipine. So what we use in CMC is mainly IV labetalol. But what you should understand is there are some drugs which you should avoid. So one of them is nitrates. So nitrates, if you give, you can cause potential cerebral vasodilatation. So already there is edema occurring inside the brain because of your bleed, and you are only increasing the edema further by giving nitrates. And another drug we should not give is thiazides, because thiazides can cause hyponatremia, again, which can worsen your cerebral edema. So these are the 2 medications. So whatever drugs you give, make sure you start your oral antihypertensive agents as soon as possible. Whatever the patient was earlier taking, you can start, or you can choose one and start. So you don't need to repeatedly give these short-acting medications. Sometimes you might get a patient whose blood pressure is very difficult to control. So here you should look at two things. Suspect Cushing's reflex. That is, because of the raised ICP, the BP is also shooting up. And here these patients will have, the clue to this will be a reduced heart rate and irregular or decreased respiration. So you should always watch out for this and take appropriate measure. Second is renal impairment. The patient may be having a already pre-existing renal impairment, or because of the hypertensive crisis, he might be having renal impairment. Another thing you should understand is the bleed itself can cause a sympathetic surge, which can increase your blood pressure during the acute phase. So you will be pumping this patient with all sorts of medication. And once the sympathetic surge is over, after 3-4 days, the BP might crash. So even after your acute phase, you make sure you monitor the BP very closely and make sure the patient is not going into hypotension. And don't forget this very important tool, that is catheter. Urinary catheter is most of the time the patient's bladder will be full and he may be in pain, and that may be the cause for his high BP. Make sure you palpate and put a catheter as soon as possible. Right. So now, having answered these two questions, the son is asking, is there any surgery which is possible to save his father? So what you should understand is, why surgery? Surgery is basically because there is a raised ICP caused by both the blood and the perihematoma edema. So we can take measures to reduce the perihematomal edema as soon as possible. Okay. So sometimes you can have a patient, the edema is not that big. So you just need not treat, but make sure your sodium level is normal. Because if you're having hyponatremia due to any cause, it can potentially increase. So if you have a large hematoma, edema, you need to start either mannitol or hypertonic saline. Okay, and what will you choose? Again, here there has been meta-analysis which has shown that hypertonic saline is slightly more effective than mannitol to control the cerebral edema due to ICH. There has been other drugs which are tried, like dexamethasone, therapeutic hypothermia, dexperoxim. All these did not show much benefit nor harm. Like now, coming to surgical intervention, here it's very tricky subject. So you can't have one size fits all. So you need to know 2-3 things before you can decide whether you need to intervene or not. First of all, you have to see whether the bleed is infratentorial or supratentorial. Okay. If it is infratentorial, you have to see whether it is only involving the cerebellum or it is involving the brainstem. If it is supratentorial, you have to see whether it is affecting, whether it is a superficial supratentorial or lobar hemorrhage, or if it is a deep-seated superficial supratentorial deep-seated hemorrhage. Also, you need to see whether the patient already had an intraventricular hemorrhage. So infratentorial hemorrhage or supratentorial hemorrhage can cause an intraventricular hemorrhage. So without knowing this, you cannot be very clear about your surgical intervention or when to call neurosurgery. Right. Now we'll look at these areas one by one. So cerebellar hemorrhage, infratentorial cerebellar hemorrhage, this is very clear. If you have a large cerebellar hemorrhage, more than 3 centimeters in diameter, especially if it is associated with the brainstem compression or hydrocephalus, it's a clear indication for surgery. A lot of studies which are shown which these patients benefit with surgical decompression and hematoma evacuation. That is infratentorial cerebellar ICH. What about brainstem hemorrhage? So this is a patient who has a pontine bleed. So here there is no role for surgery because the bleed is inside the pons. There's nothing to evacuate. I mean, like it's inside the brainstem. So these patients, nothing we can do. Now coming to the supratentorial hemorrhage. So you can have a supratentorial superficial hemorrhage. We had 2 trials which looked into this. One is called the Stitch trial, and where they did early surgery, less than 24 hours versus conservative treatment. And they looked at the Glasgow outcome scale in these patients at 6 months. So this trial was a negative trial, but however, this trial gave us some important points. The patients who did worse with surgery were the ones who had deep-seated bleeds and who had intraventricular hemorrhage and hydrocephalus and low GCS. So these patients didn't do well in this trial. The patients who benefited were the patients with superficial lobar hematomas, which was less than 1 centimeter from the cortical surface without intraventricular hemorrhage. So this was the important takeaway points from this trial. And based on this, the second trial was done, which is the Stitch 2 trial, where again you have patients who presented within 2 days, and surgery was done within 12 hours of randomization. And here the GCS has to be at least 5 or 6 with superficial bleeds less than 1 centimeter from the cortex without intraventricular extension. So this was a negative trial, but it was not statistically significant, but there was a clear survival advantages in patients who underwent the surgery. And other thing, when they analyzed the trial, they found was the patients with a poor prognosis did better with early surgery. So the key is to pick up patients who are potentially going down and then subject them for early surgery. So when you analyze these trials further, they found that the non-significant advantages observed in these 2 trials could be due to mixing of patients who benefited from surgery and those who were harmed. Okay, so right now we know which patients will benefit. The patients with the GCS of 10 to 13. So you should not wait for the GCS to drop below 10, or also if you should not operate on those patients who are very good GCS, say 14, 15. So that is one key thing. Second thing is, you do surgery for small lesions, it's not going to benefit. You have to have a large volume lesion, at least 30 to 35 ml. And you have to do surgery early within 48 hours of onset. And the best result will be for those patients who have a superficial bleed, which is less than 1 centimeter from the surface, with no intraventricular hemorrhage, and not too old patients. Median age was 65. Now, if you have a very large hematoma like this, you can consider doing a craniotomy for as a life-saving measure, as we do it in ischemic stroke. So there are trials which is ongoing looking at this type of patients. Now coming to deep-seated supratentorial hemorrhage. So this is another very common type of hemorrhage which we see in our daily practice. Deep-seated supratentorial hemorrhage, like this patient who has a thalamic bleed. So right now what is being done is what you call as a minimally invasive clot evacuation. So you do a stereotactically you can go into the clot and then a small burr hole and then remove the bleed. Now people have tried combining this with what you called as you put in a little bit of tissue plasminogen activator. What you use it for ischemic stroke, you put a catheter, put some TPA, so the clot will become more like liquid, and you try to aspirate it. So there has been trials which I looked at it called the MISTY trials, MISTY 1 and the MISTY 2 trials, which again this the last word on this is not yet out. Now coming to the intraventricular hemorrhage. So you have a patient here with a thalamic bleed with a intraventricular extension. So these are patients who has a very high mortality, because they can develop obstructive hydrocephalus. And also, as we saw in the pathophysiology, these patients will be massive release of neurotoxic substance associated with the hemorrhage. So these are the patients who will benefit with the external ventricular drain. So you put a drain into the ventricle and let the blood and the CSF come out, which will decrease your ICP. So any patients with the intraventricular hemorrhage with a falling GCS and hydrocephalus, or there is evidence of any herniation, this is the treatment. You have to put a EVD, and also you can give them hyperosmolar therapy with either hypertonic saline or mannitol. So here also studies have been done to see whether we can again put in some lytic agents into the ventricles. So by the time you put in all these drains, the blood might have already clotted inside the ventricles. So what about putting in some TPA and making the blood, lyse the blood and then take it out? So there has been trials, the CLEAR trial or the clot lysis in intraventricular hemorrhage trial. So again, these are all newer trials, which is the results we have to evaluate and see whether these are beneficial for the patients. Okay, so having answered all these three questions, I'm hopefully that you'll be able to answer these three questions now. When how to evaluate the patient when they're serious or not, the prognosticating, and the medications. Not much. We can only reduce the blood pressure in certain targeted patients, and some surgeries are there which will be beneficial. Now, having answered all these questions, there are some, you find this patient is having ischemic heart disease later on. Okay, somebody came and told, okay, this patient actually is having a ischemic heart disease. He is post CABG patient and is on treatment. So again, you need to answer some questions from the management point of view. The first thing is, should you start DVT prophylaxis? Okay, like in ischemic stroke, you start or not. The second is, when to restart your antiplatelet agents. If the patient is already on anticoagulation, when can you restart? And whether you should give anti-epileptic medications. So these are all practically relevant points where you need to know a little bit about. So first, coming to the prophylaxis, what you should understand is DVT risk in ICH patient is much more than ischemic stroke. So you have to give these patients prophylaxis with low molecular weight heparin. But however, you can start low molecular weight heparin after you document there is hematoma stabilization. Okay, so what you need to do is you have to prove that the hematoma is not expanding anymore by repeating a plain CT at least 24 hours from the last scan. So if that scan is stable, you can start your low molecular weight heparin. Till then, you can use other measures like pneumatic compression devices. Okay, so this you have to do. The second is restarting antiplatelet agents. So here also, similar to starting venous thromboembolism prophylaxis, you have to repeat a scan, document there is no hematoma expansion, and you can start your antiplatelet agent. This was proven by the RESTART trial, which was a randomized trial looking at restarting patients on ICH with antiplatelets. Now, coming to seizure management, you need not give prophylactic anticonvulsants. Okay, so no prophylactic anticonvulsants. And for patients who have seizures following an ICH, you can start treatment with anti-epileptics medication. And the duration depends on when you have the seizure. So suppose a patient has an early seizure, day one, you can consider stopping your anti-epileptics after 6 months. If it is a late seizure occurring after 48 to 72 hours, you might have to continue for a longer time or even lifelong. Now, the important thing here is sometimes you might get a patient following the ICH is not waking up. Your scan is not looking that bad, but somehow the patient GCS is remaining low. This is a time when you should suspect what you call as non-convulsive status epilepticus. So you should do a continuous or a prolonged EEG monitoring for these patients, and that will pick up this non-convulsive status. So the patient may not have clinical seizure, but he may be having a non-convulsive status epilepticus. So this is important to understand. Now, what about restarting oral anticoagulation? So this patient, some patient has atrial fibrillation. He was on warfarin. Now he has come to you with the ICH. So when you restart your oral anticoagulation? So this you should individualize the patient. You should assess the risk of recurrent hemorrhage versus thromboembolism. And if at all you are restarting anticoagulation, you have to make sure you start a direct oral anticoagulant like dabigatran or apixaban or rivaroxaban over warfarin, because studies have shown that direct anticoagulation, all these direct anticoagulants has less chance of intracranial bleed compared to warfarin. So, however, if your patient is taking anticoagulation for mechanical heart valves, we can't start this. We have to give them warfarin. So these are patients who might consider LA appendage closure devices. So these are, you know that in patients with atrial fibrillation, most of these clots are lying in the atrial appendage. So there are now device closures where closure devices where you can seal off this LA appendage. So the patients will be safe from getting a stroke. Also, if none of them, the patient is at a very high risk of rebleed and none of them is possible, at least you can start antiplatelet monotherapy, which is not as effective as warfarin, but it will do some good. Now, what about recurrence of intracranial hemorrhage? So there has been a study which looked at almost 20,000 patients with intracranial hemorrhage. And they found that the first year recurrence is almost around 2%. But if you follow them up for the next 10 years, the recurrence is almost touching 10%. Okay. Not only recurrent ICH, they are prone even to get hemorrhage, ischemic stroke. Up to 2 to 7% can have ischemic stroke subsequently. So, who are the patients who can get recurrence? So these are patients who are older, around more than 65 years, who carry the lipoprotein E gene, that is E2 and E4 alleles. And those patients who already have asymptomatic microhemorrhages on the imaging. Like if you see MRI, sometimes you'll see a lot of microhemorrhages. So these are the patients who are prone to get recurrence. And studies have shown that the only way you can prevent this recurrence is by very, very tight BP control. That is control meaning you have to have a consistently low BP of 130/80. So this is to prevent further bleeds in this patient. So in conclusion, like ischemic stroke, intracranial hemorrhage is also a medical emergency. Because as you saw, we can take some measures to prevent the hematoma expansion if you treat them early. And selected patients will benefit with surgical intervention. And you have to individualize your patients for secondary preventive measures to prevent both recurrence of ICH as well as ischemic strokes. Okay. So I'll take any questions if there are any.
I think there are some questions.
Sure.
Sir. First question is, how should we treat a patient with an ischemic stroke that has hemorrhagic transformation?
Yeah, so this is ischemic stroke. So when there is a hemorrhagic transformation, first of all, you should grade it. So there is a grading for ischemic strokes having hemorrhagic transformation. And second thing is you should see whether there is a symptomatic hemorrhagic transformation or not. So you call a patient to have a symptomatic hemorrhagic transformation if the NHS score increases by 4. Okay, and if the hemorrhagic transformation is causing severe mass effect, and those are the patients you might even consider decompressive surgery. So that's a different group of patients who doesn't, I mean, these things which we described now doesn't hold good for hemorrhagic transformation of a ischemic stroke.
Another question, sir. Any role of using both mannitol and hypertonic saline?
Yeah, we can use it. Suppose you're desperate and nothing else we can do, we can use both. And usually, like suppose a patient sitting on the fence, surgery, no surgery, we can use both and by time.
And how much dietary sodium should we give to a patient after hemorrhagic stroke with hypertension? Should it be low or high because the edema will increase?
Yeah, so basically you have to measure your serum sodium and make sure you don't have hyponatremia. Okay, so hyponatremia means you can potentially induce cerebral edema. So anyway, the patient may not be taking for the first 1 or 2 days, it will be kept for oral. So you can measure the serum sodium and adjust your infusions.
I think this is again the ischemic stroke with hemorrhagic transformation. Should we withhold antiplatelets initially and then restart?
Yeah, so here again, it depends on your, so if you look at hemorrhagic transformation, it can be, there is one classification called Hindenburg's classification. You can look it up. So there is like the first, the smallest hemorrhagic transformation you can have, it's called petechial hemorrhage. Which is you can, if there is only petechial hemorrhage, you can continue your antiplatelet. Then you can have, like subsequently, you can, the stage 4, you can have hemorrhage in site other than the ischemic area. So those patients with larger class of hemorrhagic transformation, you should not use antiplatelet. But for petechial hemorrhage 1 and 2, you can still continue your antiplatelets.
So one more question, because these patients are at high risk for ischemic stroke also. Should all of them be put on antiplatelets?
Yeah, so that is what the restart trial, which was a very interesting trial, which showed that not only is preventing ischemic stroke, when they followed up these patients, the patients who were given antiplatelet agent after hemorrhagic stroke, the hemorrhagic stroke risk also came down due to some, so that was something which was funny in that trial on follow-up.
Okay. One more question. Labetalol is very expensive. Does GTN worsen worse outcomes? Definitely.
No, labetalol is not very expensive, but you have to give it. That's a situation where you don't look at the cost, and it's not very expensive. GTN we don't give because, as I told you, it can potentially increase the cerebral edema by causing vasodilatation. So no GTN.
Are there any further questions? If there are no further questions, we will close the session. Thank you so much, sir, for coming. Thanks, sir.
Thanks.
Thanks, everyone.